So hello, and we are now live. So we just have to wait. So what can you see the little the little icons in the corner of the screen, or do you just see at us?
I'm just seeing you and me.
So I can see that we have a couple of people that have jumped on board that are watching. So good evening and good morning. If you have decided to join us, let us know who you are because we can't see who you are. So if you want to send us a comment and say hello, we would really like that.
Otherwise, we're lonely. Yours was no friends.
It's just us talking to each other, which is also wonderful. So, but I think it'd be nice to just give people a few minutes. We sort of give people a few minutes to hop on. Oh, Joe's here. Hi, Joe.
Hi.
So Joe is from the Pub Scientifique team. And I think you met her when we did our prep meeting, and so she's here to see what we're up to. We've got a few more people jumping on board. So if you have decided to come and watch us, thank you. And if you've decided to come and share a conversation with us, please, let us know that you're here. Say hello to us in the comments. And if you already know that you have a question that you definitely want us to answer, might be a good idea to get that in early, because I've already got like 6 questions that I want to ask Bronnie.
And we talk. You might not get a Hi, Tim.
Oh, Beamsy's here. Hey, Christine and Nils.
Hi.
Yeah. So it'd be lovely to see who comes on board and if we can get a nice conversation going. And Ben's here. Ben is a physiotherapist working down in Tolbruch in a revalidatie centrum down there that I've been had the great pleasure to do a bit of work with and to meet their team. They're a really nice team working down there, and they're an ACT-based team, so they're integrating ACT into their work, which is cool, which we like. Right. Okie dokie. Well, I guess what we're trying to do here is, one of the things that Bronnie and I have talked about a bit is that, acceptance and commitment therapy, or integrated sort of psychology techniques into physical health, or non-psychologist clinics. Hi, Joachim. Is no,
Tim, it's not. No, not this one.
But are you wearing Bronnie jewelry?
That is an enamel of Sheba the Wonder Dog, who sadly passed, and these are my earrings.
Oh, lovely. That's so cool that you can
go left and right.
That is super cool. Yeah, so one of the things that we've talked about is that we don't get a huge platform of sort of psychologically informed physios, and it's nice to open it up a little bit. It can feel a bit exclusive sometimes, a bit closed off, and something that happens in pain centres or in different multidisciplinary clinics. And one of the things that we want to try and do is open that up a little bit so that people can ask questions and figure out maybe how they can use these techniques and why they might be useful outside of some of those clinics. Okay, so I can't imagine that there's anybody on here that doesn't know who you are, Bronnie, but just in case, do you want to just give us your elevator pitch? Who's Bronnie in a minute?
Starting now.
So
I'm an occupational therapist with a psychology degree, and I have worked in this field of pain management in various forms, from primary prevention through to long-term case management for an insurer, through to developing policy, as well as doing just clinical work. And now I teach, which is an absolutely awesome situation to be in, because we had nearly 40 people on our class last night looking at introduction to pain management, and there were a whole lot of doctors, general practitioners, which was so great, physiotherapists, OTs, psychologists, nurses, just a whole raft of different people. And that's how I spend my day. And when I'm not doing that, I'm playing in the Silversmith studio, which is cool.
Yeah. It is cool, right? You're a bit of a rock star with all that. I think it's super awesome that you can make things as well, and also very stereotypical for an OT.
Hello? Typical for
Very
an OT.
stereotypical. You're so crafty.
I don't weave baskets, but I did. In my training, I made a basket, and I still have my seagrass stool that I made in second year of OT school. How's that? And it's still going strong, and I don't want to count how many years. 1984, I graduated. So there you go.
1984.
How old it is.
Wow.
And how old I am. You don't want to go there. Stop. I guess.
Yeah. Oh, that's lovely. So so I'm just thinking about 1984, and I don't know why. Anyway, I got lost in a thought hole there. Wow. So we've got 56 people watching us right now. So I just want to say a huge, 61 people have signed in. So I just want to say a huge thanks to everyone that is jumping on board to watch our conversation. So just in case people don't know who I am, my name's Laura Rathbone, and I'm an advanced neuromusculoskeletal physiotherapist, which means I did advanced training in manual therapy. That's right. And then I went on to do extra training and in acceptance and commitment therapy, and worked in a pain management team in London, which was just wonderful, and was completely embedded in acceptance and commitment therapy, and it changed my life. So first question.
Should I talk about how I started in ACT?
Yeah, sure. Yeah. That's a nice one.
So I've worked in a traditional CBT-oriented service, multidisciplinary interprofessional service, which was an amazing experience. Any team has got its interesting characters, but what was wonderful was the fact that with the people that we were working with, they were getting to hear this consistent message. And if that's what I can encourage people to look at, is how can we work together? Because people were talking to me about medication, and they were talking to the nurse about exercise, and the GP or the doctor about diet, and it was just that whole mix. So I got into looking at ACT probably with the first few publications from Lance McCracken, and I just thought, this is what I want to be able to do, because I've always been interested in how can people flourish, how can people grow forward and still do the things that they want to do without having to be stuck thinking they've got to fix or control or somehow get rid of what's going on in their lives, because shit happens, as you know. So it's probably way back in the mid-90s, I would think, that I started looking into ACT. So it was very early when Stephen Hay was first publishing. But I didn't learn how, and I still feel like I'm a novice, because ACT is it's very flexible. There's so much to it. Deceptively simple.
I think that's a really good point. It is deceptively simple, right? So people I've been working with ACT for 8 years, so that I feel like a baby compared to you, and I'm still learning, but feel really comfortable with it because I had a really good foundation in it. But it does seem really simple, and I think people can be like, it's easy to be lulled into this idea that you can pick it up in a day. And that it's really just an extension of your own communication skills. I wonder if what do you think? Do you think that acceptance and do you think that acceptance and commitment therapy has a place in all physical health clinics, or do you think it's just for persistent pain?
I think it's applicable to people, actually, broadly. So in my life, in the lives of my son, my daughter, we've talked about ACT, and so yes, I do think it can be embedded in any practice, because hi Phil, because it's
giant mugs. Sorry,
exactly. Because it's a way of responding to challenge, and life is challenge, life is change, and how can we be nimble as humans when we face situations that we've never encountered before, or where we can't just rely on what we've done before, and where our mind can start to have a good chat and say, oh, you should be doing this, and we try that and it doesn't work. That's the joy of using ACT. And I think when we're in health, we are health people. We're meant to be not just band-aid people, or I'm going to take that pain away, or I'm going to fix this. We're not fix-it people necessarily. We're here to help people adjust and learn and then flourish, I think. So yeah.
I mean, I completely agree. I can see why it lends itself so well to long-term conditions then, like persistent pain, because what was, in a way, we're kind of at a point where we're saying, okay, you do kind of have to, it might be really important and really helpful right now to make space for this so that you can still explore life alongside it. And I think where it's harder to see the benefit of ACT might be in other types of clinics. Although once you're in ACT, it's not hard to see it at all. Maybe from the outside, it seems hard. Like I can see how ACT could be really useful in A&E departments, in GP clinics, in dentistry. I mean, I wish my dentist could could ACT me a bit when I'm having a panic attack in that chair, you know. Oh God, I hate it. But like, it's and in sort of, and like from my side of the fence, like just in, your general musculoskeletal, acute, subacute clinics where, really actually probably your skills in behavior change need to be really shit hot, because you've only got 3 to 6 sessions to get somebody to go through what could be quite a difficult health model, really, like what could be quite a difficult process of change. So I reckon it could, like, for me anyway, I think that what's happening at the moment is, and I'm guilty of this too, sort of bang the drum, like when you're working with people who are suffering, who have trauma, who have comorbid mental health issues going on, ACT can be really helpful. But actually, it probably is just really helpful in general, just in terms of helping people to anything that we do in terms of like lifestyle change or exercise uptake, or if we're trying to help someone take on new information, like, for example, education around what pain is, or what a diagnosis is, or what an injury is, or what to expect. I feel like we're probably missing a really important skill at baseline here that could really support people in these clinics. I think that doesn't always get as much attention, or we don't necessarily promote that side of ACT quite so much because it seems to have been taken up by persistent pain.
Psychosocial is what we think of as relevant only to people who've got long-term pain.
Yeah.
But anytime, so I think about it this way. So life is trucking along really nicely, and then shit happens. And we respond to that. And normally our problem-solving mind jumps in and says, oh, I can fix that. And that works really well. But then there are times when that's hard, when we might prioritize one part of our life over others. For example, when I had my concussion, that first couple of weeks was a real challenge, because I had a 15-year-old daughter who was 15, 15-year-old, and a partner who didn't know what was going on, and trying to keep my life thread just tracking through while I was grappling with fatigue and stuff, trying to prioritize. And my problem-solving mind said, well, return to work's the most important thing. After all, I was the vocational management therapist in our pain service. I jumped in, went back to work, and because I got stuck on return to work's really, really important, I started to neglect these other parts of my life. That made life really hard. And instead of being able to step back from my thinking, and this is early, this is 2 to 3 weeks after I had my concussion, I was getting hooked up into my mind that was saying the way forward is always push hard and do this. And this is what ACT helps with. It helps with that fixation on what's worked before must work today. So I'll keep doing it. And if it doesn't work, I'll just do it harder. And in doing that, forgetting I was missing out on things like spending time with my daughter that would have actually helped me. I was afraid of that stopping. I thought if I stopped, I'll never get back. And that disobeys this rule. And, that's in an acute setting. And I think the purpose of ACT is to help us respond flexibly and to give us some space from our really awesome, chattery, problem-solving mind. It gives us that opportunity to choose and to look at what matters, and then to show up to that and to make room for some of those difficult choices that, you know, say with my concussion, I had to say, oh, I need to stop, actually. And how my mind hates that, stopping. Tell anybody with pain, you know, stop.
Well, but that's the thing, right, isn't it? Because, and this happens quite a lot. We do say that to people with pain, you know, oh, well, if that hurts, stop doing it, have a rest. And actually what you're saying to someone who has worked really, really hard in order to get that bit that they're already doing, and then to take that away, you're going to hit conflict straight away, because, you know, what you not only are you going against the grain, but you're actually starting to take something off them that they've achieved.
Yeah.
And
the
that
mind says, that's who I am. This is important to me. And yet it's really easy for us to hold two contradictory values in mind. I want to be really awesomely fit, and I want to have lots of downtime and chill out. And I want to work, and I want to have really good, you know, we can have it all. But there are times when we have to make a choice between these incredible values and prioritize that. And our mind really likes to just jump in and say, no, you can do it all.
Yeah.
Can't. And our job as health professionals is actually to stand with that person and help them wend their way through that. And we can't do that if we focus on doing the exercises or providing the gadgets. That's only going to do a little part of that. It's not going to resolve that conflict between choice A and choice B and what our mind jumps in to tell us.
Yeah. I think you phrased, like, what you've touched on there is a really, really beautiful point, actually, because what we see in people who choose to work with us for their pain, what we see the same behavior in the clinicians that are trying to work with them, right? So this kind of rules-based, habit-based approach to clinical work, you know, I've done this before, therefore I'm going to just keep doing it better and harder and bigger from here on out, and every time the patient comes back, then I'm just going to do more of it. We're going to put more load in, we're going to do more stretches, or, you know, you sort of scatting around trying to find a new type of exercise or a new type of way of doing it, rather than actually just taking a step back and thinking, whoa, what's actually going on here? Why is this not landing? Why is this not getting me the results that I want? Or why is this not working out for that person? And I think this is one of the things that it brings up the biggest resistance to learning these techniques, is that it isn't just a theoretical, abstract doing technique, right? You really have to learn it yourself. It has to be, and maybe sometimes, I mean, some of the courses that I've been on, they really don't get to that. They really don't get to that. This is personal work. I think there are some that really do, you know, like, obviously but I think the more long-term approach to training, or that sort of like extended supervision or coaching perspective, really digs deep down into the, okay, but can you notice what's coming up in you right now? You know, your judgments, and it happens to, like, probably get contacted 2 or 3 times a week. You know, I've got a patient, I don't know what to do, can you help me? And then it's something like the patient wants a particular type of treatment, or the patient wants a particular type of scan, or the patient is, and actually what's happening is the clinician has got this really strong judgment about what is right or wrong for that person, and is struggling with their own conflict there. And that's getting in the way of them being able to stand alongside. And it's about working through that. And that's not something to be like secretive about or embarrassed. Like, that's a completely human and beautiful response within us. That's probably what drove us to be therapists in the first place. Right? That's our superpower.
Yeah.
But learning how to be with that in a helpful way, I mean, it could make all the difference from having a really shitty, stressful day where you come home and you feel like you failed so many people, or like you just don't know enough and you've got to go and study more, you've got to go and pay more, or whatever, that could be the difference, understanding that it's internal conflict within your own values as well, and your own rules and your own habits. Don't know what
It's
you
hard
think.
to do that without having somebody as a coach or a supervisor to bounce your ideas off. It's why I value supervision. So as an occupational therapist, supervision's part of our practice, and we have to have it as part of our ongoing registration. And it's not just to say, are you doing the right thing? In fact, that's rarely the case. But I personally love it when somebody says to me, can I just check that what your reasoning is, so that we get to unpack why I've done what I've done. But it's also about sharing and working our way through the frustrations, the disappointments, the joys, the what it brings up for us, that it's very hard to do if you're not in a regular supervisory relationship with somebody, not as a you're up here and I'm down here, but as we're partners and together we can work out, how to help us work through this. So it's a personal soapbox that I think that all clinicians who are going to hear people as whole people, not just as a shoulder or an ankle, that we start to look at reflective practice with somebody else, so that we just dig a little bit deeper and we don't hide from our own blind spots, because it's so easy to do.
I think that this is a sore point, right? So it really touches a nerve, because this isn't typically part of the physiotherapy model. Okay, we do have in the NHS, I was brought up with this idea that you should have a mentor or someone that's the grade above you that you can talk to, but you're getting like 20 minutes or maybe a week, or 20 minutes every 2 weeks if you're lucky. And you've got a full MSK clinic list, or in my case, I had a full sort of really looking at a full persistent pain clinic list in an MSK setting. And you've just got no chance. You're not going to get anywhere in that. 20 minutes isn't enough. You've just sat down and got yourself a coffee, and before you know it, you okay, see you later. And there's always somebody dashing in and out. It's not protected time, in my experience, and unless, perhaps it's changed in the NHS radically in the last 3 years, but I doubt it. But the biggest problem is in private practice, for me anyway. I think that it really doesn't seem to be a part of the model in any serious way. And when I think about other professionals like psychologists, for example, sort of supervision is a really protected part of their clinical practice.
It's the same for us. And I think the idea of mentoring of someone who's senior puts us into a position where we think that we are therefore subservient and we have to do, and we can almost feel like we need to model what this mentor is doing. And to me, the supervision approach is about exploring together our combined wisdom, because there's wisdom and synergy between two people. So it doesn't have to be this master servant thing. And where that comes into ACT is that we're constantly in ACT thinking about, what am I fused? What's my mind telling me? What am I avoiding or trying to control that's showing up? Am I able to stand back and sort of have this perspective from a bird's eye view of what's going on, so I can be flexible in my choices? And that's I think that's one of the things that ACT brings to general clinical practice outside of working with persistent pain, that ability to say to yourself, what kind of therapist do I want to be? So that I'm using my own values and my own approach as my context, rather than I want to be just like, whoever the latest guru is. We can do better than that, and we can be willing to be vulnerable with one another. One of the problems might be that we don't like feeling vulnerable with another clinician, and that we might say, maybe I could have done a different thing, and we can feel guilty that we didn't do it the right way. But when we're working with people, is there a single right way? Really?
No. Yeah, well, that's the thing, isn't it? And so you just said something, then I thought, what about if we were to frame it as in, like, how can I be the clinician how can I have the values how can I uphold the values that I want to uphold as a human and be the clinician that that person needs me to be? And it's that sort of like, how do I balance, what I hold dear to me at my core, and recognize in this moment what that other person needs in order to become unstuck and in order to promote health and well-being, which I think is just a really like fundamental part of our job, isn't it? And I think I've got a bit, so I've lost my train of thought.
This is live. and that's a cool thing again about ACT, is that it's okay to say, hold on,
that was stuck. It, that was my point.
When we're working with somebody, we actually think about your skills. Think about what you're doing when you're working with somebody. You are listening really carefully. Well, hopefully you are.
Yeah.
You might instead actually be thinking about what you're going to say next instead of hearing what this person's saying. You're observing. So all of those sensory modalities are being used to process what's happening between me and this person. And sometimes we get into that. We're so stuck in our own heads, we don't hear and we don't notice what is happening for the person with us. Or we feel embarrassed. This person's crying. What am I going to do? People cry, and they do. And we might dismiss that because we don't feel comfortable. And so I think with ACT, it teaches us that we can connect as humans. In fact, I would see it as the best way to augment our human-to-human contact. I'm not the guru. I'm not the therapist. I'm a human. I have a whole lot of information and knowledge, but what I bring is this attitude of, I'm here for you, and can we work together?
I think
so. We work what the person actually needs, not what we want to do to them.
I think that's a really good point, because so I've said this a few times before, and I don't know whether I've ever really brought it across the way I intend to, but I think that there's a responsibility on both sides of this fence to remember that clinicians are humans. So like the people that come to see us also need to remember that we aren't heroes, that we are humans, and there is that kind of there's this model that's set up that, clinicians are trained to be right. We're examined on, did we get the right answer or the wrong answer? We're brought up in this sort of stressful environment of passing, failing, being good, being bad. And it's all really abstract when you're at school anyway, isn't it? So it's a kind of it's a really bizarre way of assessing clinicians. I mean, I understand why we do it, but it feels a bit bizarre. But like, there's also this expectation built up in the media, and it doesn't help when we see things like, Clap for Heroes, NHS Heroes, all these things like pushing and like healthcare workers up into this higher and higher pedestal. And that what that means, as much as it's a beautiful sentiment, and I'm sure it was felt very powerfully, and I don't want to be criticized, like, I'm sure, like, we do have to remember that clinicians are not heroes. They are just, normal people with kids, and they go home, make the dinner, and they have a stressful day, and they've had a bad night's sleep, and they've got stress of themselves, and they're also dealing with their own stuff as well.
When I've worked in treatment with psychologists, and one of the things that I noticed was that the psychologists who were real with me and authentic, I remember one in particular, he was a psychiatrist actually. He said, look, I've just finished seeing this person. I want to take 5 minutes before I see you because I want to be able to give my attention to you. And what he was really saying in one sense was, I've run over time and I need to have a break, which we could see as being really selfish, and he should really just pull himself together. But what I read from that was he valued what he was going to do with me. He's sort of acknowledged his vulnerability, and I connected more with him. I've remembered it 20 years later. And so I think that showing our humanity in saying, I'm stuck, or that was really awful, the thing that happened to you, or just showing something about who we are, creates a much better connection with that person. I see Tim's just put in that question, which I think is a brilliant one. So when you're pulled into the person's story and you get upset and angry, when anger is a really interesting thing, it's energizing. It's an energizing emotion. And it's a sign, somebody's standing on my foot, get off my foot. You're breaching my my boundaries, or this is a wrong. And some of the stories that we hear from the people that we work with actually should make us feel angered. When I hear somebody who's had persistent pain telling me that they've been told that their pain is all in their head, that there's nothing wrong with them, but they just need to pull themselves together, or they've been dismissed, or they've been told, well, I've treated the inflammation. You haven't got any inflammatory markers. You shouldn't have pain anymore. Even if that's not what was actually said, I feel protective on behalf of that person. So what can we do to stop being sucked into the anger and letting that drive what we do? ACT is a really good framework, actually, because we just first of all notice that's what I'm feeling, and make some room for it, and say, hey, I just need a moment to notice my response to your story, your trauma story, your the fact that you've been stigmatized, that you've been dismissed. I just need a moment, so let's make some room for that and let's experience it. And what we do by doing that is we're demonstrating our willingness to hear and bear witness. And I think I use this term quite a bit recently, this idea that part of our job is to bear witness without necessarily doing a thing. Just be present, because that is a gift that we can give people.
It's also a really strong message, though, isn't it, Bronnie? Because what you're saying is, I'm not going to jump in and take that away, because you're already modeling to that person, okay, this is allowed to be here. We don't need to quieten that down straight away. We don't need to shove that away. We're modeling that this is allowed to be here and it's allowed to be present. So that's, I think, also,
paradoxically, by doing that ebbs away faster. Because if we ignore something, like the spider phobic who can't see the spider anymore, what do? You start going and looking for it, or it bubbles up by itself without the controls around it. So you're modeling that it's okay to be sad, it's okay to be angry, and let's make some room and be okay with that, is a power. It's another superpower that we have.
But we're not heroes.
No.
Yeah. But it is people. I think labeling is one of those things that what we know is that people that tend to get, I think they did this study with anger management or something, that where they were looking at people were able to self-regulate their anger as they were able to improve their labeling. So labeling of emotions, something that women typically are better at than men, I think. So men don't have the same socio-cultural development and influence as young girls tend to have. And that, I think there's some work around things like toxic masculinity and how that plays a role in men just being like and women. I'm not trying to say this is a male issue or a female issue, but in terms of this particular work on anger management, it was in men, on actually just being able to label their emotions accurately. So fear as opposed to anger, and these kind of jealousy as opposed to hate, these kind of things, is a technique and a skill that ACT can allow space for and can support and facilitate. So that just in itself, just having appropriate and accurate labeling systems, cognitive labeling systems, can be really helpful.
Yeah, it gives us, instead of that I'm upset, which can mean a whole raft of things, we drill down and say, well, what does that look like? Oh, and we find out when we do that it might be grief. It could be a sense of vulnerability. It could be shame. And my most powerful group program is when I had a group of men who were talking about the loss of mana they were mainly Māori men, who were saying, I've lost my sense of my mana, my authority, my sense of respect, because I can't do the things that are expected of a Māori man on a marae. We're meant to be the people that are in charge, who direct and lead, and I can't do that. That was hard for them to say, because everywhere in our culture is this idea that a man should be strong. So imagine if you have got a bout of back pain and you can't do those things. That's why we, from the very beginning, I think, recognizing that emotions are part of our experience and our response to what life throws us, and making a little room for those just gives us more power in terms of how do we choose to respond.
Yeah. Definitely, it's a really powerful practice. So I just noticed that I'm really sorry if I say this incorrectly. Cerise, Cerise. I'm really sorry. It's 10:30 at night. But she's asked a beautiful question. She says, have there been any cases where integrating ACT has not been effective or helpful? What's your thoughts?
What does not helpful mean? Is my first question. Is it because what is the point of what we're doing? And part of that is to help people flourish and work through and be responsive to what's happened to them. And I don't know that. I think if we do it ineptly, if we say to people, you must accept your pain, well, you deserve to be slapped. I'm sorry. That's awful. I would hate that to be told. And I think sometimes it's the idea that we must accept that shit happens without at the same time acknowledging that we have feelings. Acceptance isn't resignation. It's not giving up. It's not oh, well, I don't know what else to do, so I'll just do this. That's not the point. And so I think it's less about whether ACT works or doesn't work. It works to a greater or lesser extent. It's about how well we do it. And because it's not a thing, it's a series of processes, we can start with a little bit of willingness. And then we can grow that, or a little bit of flexibility, or a little bit of cognitive diffusion, and we can grow that. So I see it as a much more progressive, it's a process-based therapy. It's not just a magic bullet. Yeah.
And I think this is where we have to, like, the sort of the concept, or the way that sort of things like the biopsychosocial model and ACT and psychologically informed therapies can be talked about, is like it's a kind of thing that you do when you've exhausted everything else, or when you have a particular person that fits a particular sort of prejudgment as to what's going on with this person. Like, I think the problem is that it, just like you said, it's not necessarily whether ACT is helpful or unhelpful, because in and of itself, it's not really one or the other. It's just a series of processes that we can use or we can not use. But the idea that it can be somehow done to somebody, that I think could be quite unhelpful, and create a lot of misinterpretation, misunderstandings, and a lot of then resistance. And it also just means that you can't then really go there again down the line, because somebody's already thrown it at a person in a sort of haphazard way. And then when you actually do try to integrate it, people are smart to it and can hear the words coming up again, and they don't want to go there again. And I think but I think, like every cognitive and behavioral approach, it doesn't necessarily mean that that the person responds immediately to it and that all of a sudden their life gets better. I mean, I can think of many situations where actually what was really hard was we just weren't able to break through some of that resistance, and it was really hard for that person to take up some of those skills, and
It's about readiness, isn't it? With anything. So we could say, well, exercise for pain doesn't work if we applied that to somebody day one of their acute low back pain. Let's launch them into a series of strengthening exercises. That's just wrong timing. And I think we can sometimes believe that, like you said, it's a thing that we do. Here's a modality, I'll do it. Whereas I feel it's much more of a process of living it.
Yeah.
Yeah, it's really hard to put into words. And I guess it's a distinction from, say, CBT, which is quite, it's very talky, very, you do this, this, and this, and this, and then by the end of it, you've got these skills. ACT is not like that. It's not nearly as prescriptive. No. And so you can introduce little bits in terms of your approach multiple times in lots of different ways. There are so many different ways that we can do things like mindfulness or being fully present. It doesn't have to be, and I've seen this, where somebody says, right, this process is mindfulness. Let's be fully present. And they start doing, I'm going to do, meditation. And you've got somebody who's a real hardcore bloke whose way of being mindful is when he's out fishing or he's out on the treadmill or he's running. That's where it's not the process. It's actually about how we're applying it and what we're doing.
And that comes back to... And it comes back to, doesn't it, that acceptance and cognitive and psychological flexibility, this thing that we're trying to achieve and trying to facilitate, just always has to start with the clinician, because that is a clinician that isn't being psychologically flexible, isn't being contextually flexible, isn't recognizing that this just isn't going to land in that room, and not being able to update and respond spontaneously to that, and that's it. Like, meeting people where they are and speaking their language, it sounds really simple and it just sounds really, really easy, but it's really bloody difficult to do, because you have to really dig down. You have to put your own self away a little bit, and all those goals that you had. And this is why, like, just everything about physio, like the whole soap note thing. Now we're going to make our plan for what we're going to do in a week, when that person has had a whole week's life in between, and it's like, it's just not being. We have to be flexible. We have to be able to change our plan and change our language and our body language, our body behavior and our environment and the setting in order to help move people along. I just noticed that Keith has asked a question as well. Hi, Keith, first of all. Keith also is going to be coming and doing a Pub Home Brew, which we need to talk about, because Bronnie is going to be joining Le Pub Scientifique on the 18th, which is 8 days away, and delivering a Le Pub Scientifique home brew. And we're going to be talking even more about this.
We can talk about the elephant in the room, what when it doesn't work. And how do we respond to that? And is pain reduction the only outcome we care about? We'll get on to some really interesting stuff.
So Keith has asked, how do you see the person living with pain's willingness or acceptance affect ACT? How do you see the person living with pain's willingness or acceptance affect ACT? Am I reading that wrong?
Wondering whether the person's ready to say it's okay for me to live with ongoing pain. I see that as a process, because in the beginning, when we have an acute pain problem, we don't expect that it's going to last for a long time. Like my concussion, I expected I would be right within 48 hours. 2 years later, I was right. That's how when something happens, we don't expect it to have long processes. And so we can, when we're thinking about ACT as a process-based therapy, and we think about acceptance as I now am giving up the fight, or something. Actually, in pain, it's not always the pain that we need to learn to accept. Sometimes it's that I need to change the way that I've been living my life. I might need to stop a little more often. I might need to be a little less driven, or I might actually have to push myself in these areas a little bit harder, or I might have to make a change. And ACT is really about responding to change. And so I think we can expect that somebody will flick a switch and go from, I want my pain gone, to, oh, I'm fine with it, as if it's a switch, and it's not. And it never has been. It is a process of willingness to say, okay, I'm willing to just open that little bit up a little bit more and have a little bit more room and start doing some things that matter in my life, and start to excuse me, and start to grow that what my life is about part, so that it's bigger, so that the pain part correspondingly becomes less dominant, less prominent in life. So I don't see it as much as this is how to cope with living with persistent pain. You just got to give up and live with it. I think it's much more a process of, how can I make my life bigger, more, flourish more, embrace that change, and be okay with that when my mind is probably going to nag at me, in concert with other people around me who are probably also saying the same things, like, shouldn't you fix that pain? Haven't they tried this? Auntie Mabel had that. You should do it too. And life will only be the way it was if you get rid of your pain. And the problem is that when events happen to us, we change. Everybody changes. My experience of having concussion has changed me. I'm fine now, but I had 2 years of change. That's changed who I am. And even a sprained ankle can change us. Like, I'm not going to wear those stupid shoes ever again on rough ground. I mean, seriously. In fact, I wear flat shoes now. But every event makes us change a little. And I think what ACT is doing is helping us recognize that change is not a bad thing. That's trying to control change is probably unhelpful.
Yeah. And I think that's, I think that's it. So, and also I think sometimes I'm just thinking about a person that I've been working with recently, and how, it's that moment where someone comes to that, and we call it in ACT, don't we, call it creative hopelessness as opposed to learned hopelessness. It's that moment where someone goes, oh yeah, this is persistent pain. This is what this is, as opposed to sometimes what they've been fed for many years is, well, if we just do this surgery, if we just do this treatment, if we just do this approach, once we've cracked it, once we've got rid of it, then you can start your life again. But what we tend to see on our side of the industry is people that have been waiting for 20 years for that to happen, if not longer. And it's sort of like, okay, now we're going to titrate this conversation around, well, actually this is a long-term condition at this point, and now we need to start coming to a place of realization, so that we can build a life with it. And part of that, I think, is really useful, is actually it is about allowing pain. So you're not only dealing with, well, how do I make my life bigger? You're also really directly dealing with, what do I do when pain comes up? Like, how do I actually be with that? What skills do I have that are helpful and unhelpful? And I think that's also one of the really powerful tools that can powerful processes, because this is not a tool, that can translate across areas of healthcare, right? What do I do when this happens? That I think we could really be tapping into. Yeah.
I kept thinking then of things like diabetes and COPD and osteoarthritis in your feet, and things that we don't have fixes for, or that require life adjustments. That all of those, we can use those. I can try to pretend it's not happening, go la la la, it's not happening, and go back to the way my life was, but that's unworkable. And I can also choose to follow slavishly every rule, especially thinking about diabetes, follow every rule and still find that my diabetes gets out of control, or that it does stupid stuff, or that I feel like I'm losing everything. I think the workability rule from ACT is the thing that appeals the most to me. Is this working? So instead of saying rest is really bad for people with pain, we can say, in what context is rest helpful? And in what context is it not working for you? It's really hard to have your 4-year-old birthday party when you use rest as your primary way of coping. But it's just as hard to use pacing for your 4-year-old's birthday party, because in the middle of it, you're not going to say, oh, stop the party, stop, I'm going off to do my pacing.
Yeah.
And we can apply as health professionals, because we want to have the answers, we can apply these rules in a very ham-fisted sort of way that doesn't actually reflect this person's reality, this person's life. It's like the idea we've all got to do exercise, and, you know, exercise must look like this. I'll get onto my lycra-clad men sweating in a gym with loud music in a minute. That's not what movement is about.
Is that a good thing or a bad thing? Can we just establish? Oh, right, okay.
Very sweaty, noisy, and yuck. And I don't do it.
Sounds wonderful to me. No, but I think that's it. I think the workability, like when you throw in the workability rule and this idea that actually it's irrelevant what we've come up with, and so sleep hygiene is a big one for me. Like, thou
shalt not.
Like, this is another thing.
You must not read in bed, because that's bad. What? I'm doing it all my life.
I mean, it just doesn't make sense to me, this, when, you know, and we apply it in a very rigid way, and we're saying to someone who might have been living and sort of managing and coping the last 10 years with going to bed at 1 o'clock in the morning and waking up at 12 o'clock in the afternoon, why does it matter that they have a different? It only matters if it matters to them. It only matters if they say, I'm not able to function, I'm not able to commit to the things that are important to me because of this routine. But actually what most people are dealing with is the fact that they've been told they're not allowed to do that. And I'm like, well, you do what you want. You're an adult, it's your bed.
Yeah, I'm glad belly dancing. It's a thing. It's really
a definite thing.
So is gardening. Unfortunately, so is housework. So I have to reframe my housework, especially vacuum cleaning, as my movement opportunity. I'd rather go for a walk with the dog. Yeah.
Oh, I think, yeah. Blooming heck, Bronnie. It's 52 minutes.
This is what happens when we get together. Be careful, guys. When we meet in real life, just letting you know, we've never actually met in real life. But when we do,
never touched each other.
Watch out.
I know. It's mad. I keep forgetting that we haven't actually met each other. It's a strange thing, isn't it? I'm just going back over my questions and thinking, have we? Oh yeah, I'm just going to say one thing to you, Bronnie. Soft skills.
Oh, soft skills is like saying I'm going to do my subjective and then my objective. Sorry, physios, but really. So why do I not like that term? Because that suggests that they're not hard. They are not easy. I can tell you that. They're the hardest things, and I think we think that we do really well with communication, because after all, we're people, and we've got into this business to help people. And we probably did communication skills in our first year at uni when we were doing our training. It might have been mentioned in one or two sort of lectures.
Yeah.
And then we think we've got it made, we're sorted. And actually, things like knowing how to ask open-ended questions, and then how to respond when the person answers in a way that you utterly did not expect, and then follow the lead of that that is not easy. And keep within a time frame, and get the information that you do need. These are not easy skills, and we just don't like learning them. Damn it, because we think we're great.
And also because they are really, really difficult. Like, it requires us to go to really difficult places, right? That's why I think it's so offensive that it's called soft skills. I mean, I know it sounds lovely, but it's also, you know, it's another thing, isn't it? It's a soft is associated with women, that maternalistic approach. Yeah.
Psychology, fluffiness.
And it's that idea.
Psychologists do hard and crunchy research, and that's all they've got as tools are conversation. And we talk about that as being soft.
No, it's bad ass.
These skills, and we want to, diminish them.
Yeah.
Can I get on to my subjective objective? Can I please?
Of course you can. Yeah.
So the reason I hate that is because when we think subjective, and I absolutely hate it. When we think subjective, we think, not that useful, not real. We'll just chuck it over there. Objective, that's the real stuff. That's the real stuff. I can tell. Well, just how objective are our tests? First of all, we choose them. We choose which ones to use. That means we've subjectively identified the ones that we want to use. That's subjective. Then we do them, and we choose to do it either in the way that we were trained, which was how many years ago, or we do it our own way. So who knows if that's actually the way it was supposed to be done? How many versions of Timed Up and Go have you seen done? Just Google. Just go onto YouTube. You will see a million different ways to do it, and which one is the most accurate. And then we use these norms that could be based on a population completely different from us, particularly if you're in New Zealand, different age groups. And then this is one shot in one place at one time, and we think that's a hallmark of how this person always does this. Sorry, I'll stop raving.
No, you don't need to stop, because you are preaching to the choir. So, but like, I think you're right. I mean, there are useful elements to some of the tests we do in the objective part of our assessment, but knowing that it's not objective is important, and knowing why we place such a high value on it. This idea of what we can see and measure is more valuable than what we can't see and measure and touch, and all of that. We need to understand, like, the background to the development of our healthcare model, the philosophy of our science that we're using. Why is that culturally happening, that we value these observable, measurable, touchable things, when actually what we're learning about conscious experience is that all of that stuff, we have no idea how this is coming through. Like, how does physiology translate into a conscious human experience? So when you're doing that objective test, how is that physiology translating into the conscious experience that is being reported to you? And what are you seeing? And actually, what are we really measuring? And that brings me back to, like, psychometric testing and self-reports as well. Like, are we really testing what we think we're testing? Even though we might be able to get some validity on, and we some construct validity, actually, are we guiding people through a language test that actually at the end of it is just a report on suffering?
I'd like to see physiotherapy think hard about using those words, objective and subjective. Other professions, OTs, talk about initial interview interview and clinical testing. How we use that?
Much better.
Because those are not value laden. Subjective and objective have this baggage around them that draws us into, this is reliable, this is unreliable, this is useful, this is not useful, this is just opinion, and this is real. And I wonder whether it's time to have that discussion around, actually, I'm doing an interview, I'm listening to you, and now I'm going to do some clinical testing so we can see what happens. And we can use that. That's a really cool way of framing it. It is. Just a thought. Why don't we hear from OTs? Good question, Tim. We're shy, gentle creatures. We hide in the background doing our knitting and our moccasin making.
all that crafting in the background.
I actually think the main reason that occupational therapists are quiet is that traditionally the model that occupational therapists use is messy, multifactorial, and very difficult to pull apart into these little tiny sort of measurable bits. And in fact, occupational therapists reject that whole idea that we can distill the essence of a person into these tiny pieces. Now, I'm in the middle, and I've done methodology for psychology, and if psychology is not complicated and messy and really hard to measure, I don't know what is. But that whole idea of trying to have a conversation about what are psychosocial processes very often, then we have difficulty articulating that. We talk about stuff like context. We talk about meaning. Now, until recently, that hasn't featured in physiotherapy discussions or psychology discussions, actually.
It's coming!
That's a new phenomenon. Occupational therapists have that embedded in their entire philosophy. Yeah. So I think part of it is a translation. How do we translate from our occupational therapy jargon to language that other professions will understand? Mm-hmm. How can we take really complex, multi-layered, contextual processes that occupational therapists see and value and use and intervene in, and help other professions who are seeing the light, that when somebody values something, when they do it in the context of their own life, that has a different effect from when we're in a clinic doing it with a safe person with some safe equipment. I like to think of occupational therapists as knowledge translation experts. Mm-hmm. Our job is to help people live really good lives in their own life, and putting what other professions do in separate venues into that world. Andrew's just saying that it's threatening that other professions are entering the space. I think it is. For occupational therapists, we've been doing this since the turn of the century, since the turn of the 20th century. And we're finding that some of the models that I've always thought of as a bit fluffy are actually very similar to the models that I'm seeing physiotherapy bring out, and saying, hey, there's this bit, and there's an interaction in the middle. And I think that it concerns me that we have a very long history in occupational therapy of understanding and respecting person-centered care and person-oriented interventions, and measuring the individual nature of what we're doing. And my worry is that we can see other professions picking it up and using an element and then believing that they've done the whole thing. Like somebody could be asking about what is important in somebody's life and talk about, well, we'll teach you how to fly a kite because that's a really good exercise and you like doing it, forgetting that there are family, there are other constraints, there are work constraints, there's contextual constraints right around us that stop us from doing it. That's what occupational therapists bring. We find it difficult to articulate it in a nice, simple, clear way, because actually life and people aren't simple.
I think you're right, and it does strike a chord, because I am one of those physios that's like banging on the door and saying we need to be doing more psychologically informed interventions, and we need to be doing more person-centered care, and all these models and bringing them forwards. And it does sometimes feel like, oh, are we sort of encroaching? But I do think what I really like about one of the conversations that you've had with somebody else, and I've watched, or we've had, or I've dreamt, I'm not sure, but this idea that we need to stop calling ourselves like pain specialist physio, pain specialist psychs, and just be pain therapists, and allow the boundaries to dissolve, and for us to become multimodal and multidimensional, multidisciplinary working environments, as opposed to monomodal multidisciplinary environments. And I think that's probably the future for pain, that we probably do need to separate off as a specialist area.
I think so.
But
we know we've done that with pain therapy, and I think Andy's thing here, that what I'm seeing from the various clinical reasoning models is that bolted on bit of, I'm going to add the psychosocial, but it's not woven together, it's not integrated or synthesized, because that's hard. Instead it's just chop it on here, plop it. That's the bit that we're trying to I think we will need to work harder on. And I guess one of the reasons I like ACT is because it is woven together. It's not a bolt on. In fact, the doing part of ACT, the embodied part of ACT, is woven within the whole picture. So bringing it back to ACT, because it's all about ACT.
No, but that's true. But I think we've seen this with physiotherapy, with the sort of the yellow flag system for noticing psychosocial issues. Actually, what happened was physios just got really good at listing yellow flags and confusing them. Right? Yeah, yellow flags are not mental health disorders. Like, we don't need to send people to psychologists because they've got yellow flags. Like, we need to. No, but I mean, it depends. But I mean, the point is that it's about having an informed ability to, think critically about what we're seeing, like to think about what we're seeing, as opposed to just reacting to these structured based assessments. And I think that's the thing, isn't it? We've upskilled parts of our therapy teams to be able to signpost and give access, but we haven't necessarily gone to that next level of giving the critical reasoning and the deep clinical thinking.
It's also, what do we do with it? So when I've seen people who've been identified with yellow flags, and the exercise-based program is exactly the same as what would have been given to that person had those yellow flags not been identified.
Right.
There's somebody else to do that job. Now, it could be an OT, but OTs are not routinely included in all of our pain management or rehabilitation processes. It could be the psychologists, but many of the psychologists, at least in New Zealand, haven't had specific pain training. And so Andy was talking about scope boundaries. I think hand therapists have shown us that we can become a specialist group. And I think if we think about most people with persistent pain, and especially early on, they don't have frank psychopathology. They're people who have a normal response to an abnormal situation. Anybody is going to feel freaked out, probably fed up, frustrated, probably demoralized from time to time. That doesn't mean that they've got a mental health disorder. It just means they're a normal person who's got stuck into this really rotten situation. And I think that's where we need to begin to start recognizing that ACT is not just applicable to people with psychopathology. It's actually it's about living as people, humans. And true. I totally agree. So we should include more pain in our undergrad education. We shouldn't expect that people be fully competent. We never expect that of new grads anyway. But
I don't expect that of anyone, right?
No.
So nobody knows the whole science of pain.
No. And that's why IASP was set up as an interprofessional organisation. It's always been interdisciplinary. It says we all learn the same stuff, and the whole educational curriculum is about working together, so we have the same understanding, we can use the same language, we can help this person in front of us hear a consistent message about what's going on. It's not quite there yet.
No, and it's very difficult because the institutions do take a lot longer to change, and there's a lot more financial investment and egos invested in the teaching, and these are people's jobs. The teachers need to upskill and update their knowledge regularly, probably more regularly than they're allotted the time to do, and that there is the input going into it as well, which is so it's a very big nuanced issue, isn't it? And it's understandable.
It's huge. And yet we do expect, our long-term expectation is, I think, that as a group of allied health, that we will be able to work together across. We won't have these turf wars. We'll recognise that in pain, at least, we work in a complementary interprofessional way, and that's our strength. In fact, when we look at the numbers, when we compare our allied health numbers versus the biomedical numbers, we've got more people who are not medical involved in helping people with pain than any other group, and yet our unified voice is pretty weak. And I'd love to see us be a lot stronger. Not saying exercise is the answer to everything, but actually allied health are your workforce.
That's right. That's right, because it's quite interesting that people just don't know that there are other therapies available. Like once I've noticed this over the last few years, that if it's not an injection or a piece of surgery or medication or some kind of like pain rehabilitation group or pain management group, actually people don't know that there are sometimes other therapists who are more specialized in pain, and that you are able to work in different ways, and that for some conditions symptom modification approaches are possible, and for some syndromes, and I think there's just a lack of knowledge. Like, we're just not getting this out there. We're not cutting through the noise of the
do this exercise to fix your knee pain.
Or those silly muscle scraper things.
There's a whole lot of one-shot things out there that say, remove the inflammation from your knee by doing this exercise. Well, first of all, is there inflammation there? Is it not just a painful joint? And secondly, how else could that person do life without having to do that? Can they do it in other ways? That's the and then what do we encounter with the thinking and the emotions around making that change?
And that's a fact. So I am going to bring this to an end because we are 12 minutes over what we expected. So just before,
that's normal.
That is very normal. Only 12 minutes, I think, is good. Just before we all go, I just want to share with everybody. I don't know if you can see this. This is exciting. I want to share. Oh no, it won't let me. Oh, that's annoying. So what I will do is I will put up after this talk I will put up a link to Bronnie's Le Pub Scientifique Home Brew, which is under the title "Stop Focusing on Pain," and so that you can see how you can get involved with that. It's a great opportunity to see Bronnie again. On her soapbox with gin and
in the morning. We'll see.
So if you're interested in joining Bronnie on the Le Pub Scientifique, you can just type in Le Pub Scientifique right now onto Facebook and go over to our group, and then you'll see the link to Bronnie's Home Brew, and you can see all the others. We've got a few other really cool people coming up as well. So we've got Tash Stanton as well, and we've got Melanie Knoll, and we've got Keith and Gilletta are going to come and do an awesome session, which we hasn't come out yet. So do head on over to the Facebook page for Le Pub Scientifique and
your ACT group.
Yeah. I'm super proud of it. I feel a bit like, I don't know, awkward, but I have my ACT course is now out, up and running. It's an extended course, so it's not just a 2-day shove ACT down your throat and see how you go. course. It's a sort of a slow approach to learning so that we can share and develop and supervise each other and reflect with each other and take a good few weeks to do it. So if you're interested in that, you can always head over to my page or the website, which is laurarathbone.com, and you'll see it all there. Thanks to everybody that stayed with us. Really it's been really cool to have you here, and thanks very much for your comments and all your support and all your thanks. It's been lovely just to have so many people involved with us. Like Bronnie and I just love talking about psychologically informed therapy.
We just like talking, maybe.
We just like talking. But we stayed on topic. I'm really proud of us.
Did.
Yeah. So it's just really nice that we were able to share it with you. So if you have any questions, you know where we are. Get in touch, get involved, and who knows, we might even do another one in the future.
Yeah, that'd be great.
That would be great. So thank you very much, everybody, and I will sign our broadcast off. So take care and ta-ra.
Bye.